anybody else like to contribute to that?
Well, I finished medical school in 1983 and went to Georgetown and the University of Utah, and we never really talked about death a whole lot in medical school, but it's kind of ironic because, you know, life is fatal and none of us is going to get out of here alive. So you would think that we would have talked about that a little bit more, but the discussions began to happen, you know, I can remember having these discussions, and even, I actually had them more before I went to medical school. I was a kidney transplant coordinator at the Washington Hospital Center in Washington, D.C., and had to deal with death and dying issues, usually very sudden, usually with families that weren't prepared, about donating organs and trying to build a way that they could take something that was a tragic event that had happened that they were not expecting and turn it into something that was positive, which was kind of the same sort of analogy of, in a different sort of way of what goes on in the transition between life and death.
I think a couple of things, and sitting here I was just kind of doing my math, and Elizabeth Kubler-Ross's book, where she laid out the 5 stages of death and dying, and really I think her book was the beginning of an ongoing dialogue in this country about death. I think prior to her book it was totally silent. And the story Elizabeth told when she wrote the book was she was at the University of Chicago, and she had some medical students who were interested in death and dying, and she said, well, just go talk to them, go talk to them. She was this little bitty German lady. Go talk to them, go talk to them. And so the med students went out to all of the nursing units in the University of Chicago, and big, 1,000-bed hospital, and they come back to Elizabeth the next day, and they said, there is no one dying. And she said she just looked at them, and she said, there are people dying here. And they said, no, we went and we talked to every nurse's station, and not one nursing unit had a patient that was dying. And that really is how she started her career. So I think in some ways it feels like we've been at this for a long time, but if in the grand scheme of things, that's less than 50 years since her first book came out. And I also think that there's the medical model, how we view it, but I also think the public also have very distinct views of death and whether death is a failure and a medical catastrophe, or if it's a normal part of life. And I think medicine can't get too far out ahead of the public, and it's the stance that we do together as we progress.
It's very similar within psychology as well, that not a lot of psychologists are trained to work with people right at the end of life. So as in medicine, it's very new as well. And a lot of the people that I work with, we really end up emphasizing that the potential for growth and development is there throughout someone's entire life until they take their very last breath. So looking at the final stages of life as just another developmental stage that all people go through eventually really helps to normalize it and destigmatize it and make it a little easier for some people to talk about and grapple with.
The medical model is evolving. It's important to recognize before 1926, with the discovery of penicillin, much of medical care was really palliative care near the end of life. When I was in training, I still heard the phrase of pneumonia being the old man's friend, because it was a way to transition quickly. But the idea of heroics in medicine really came in with the pharmaceutical model, and it wasn't until really the early 70s, late 60s that we began to realize that the pharmaceutical model was not going to be the be-all and the end-all, and we weren't going to live to be 120 or 140. That all of a sudden the whole rise of chronic diseases became an issue and began being talked about in the 60s, and that it is now coming full force, which of course comes as part and parcel of the growth of integrative medicine and palliative care.
I love how you said that medical model is evolving. I was thinking as each of you were speaking, we have a course that I'm fortunate to team teach with a group of others for the first and second year medical students at OHSU. And usually we have about 15 students. It's an elective. And by far and away the best part of the class is that we assign a patient to them. and they visit the patient weekly for about 10 weeks and just sit with them and ask, tell me about your experience. Tell me what it's like to be living out the last days and months of your life. And this year we had to turn students away because it was in such high demand. And what the feedback we get from the students is that it helps them be much less afraid of this whole area of medicine. And the feedback we get from the patients is that they feel like they still have a purpose and that they're able to teach, which is really important.
Any questions?
Don't be shy.
Many of you have mentioned the medical model, the relationship to death and dying. Is there a difference between the medical model and the complementary and alternative medicine model or philosophy in the treatment or the care of dying patients?
Well, I would like to think that the medical model is moving toward the model of integrative medicine in terms of its approach and recognizing its limitations. I'm sure that you could go into an ICU and that might not be quite so prevalent sometimes, but I think it is changing. I mean, 1990, 3 medical schools had ostensibly some course somewhere on integrative medicine, and now it's 75 of it, and the consortium is having a conference in May in Las Vegas that'll have 1,000 people there. And so and there's linkages now between the academic medical centers and conventional biomedicine and the complementary and alternative medical centers, and so I think it's beginning to come together. I think. I hesitate to say that because I may be so far in the integrative model that I don't see what's going on in the heartthrobs of OHSU and the ICUs. So I don't know. They can answer that better.
Well, I can comment on our cancer program where we have on our faculty an acupuncturist, naturopath, cancer-trained massage therapists, yoga teachers, mindfulness-based stress reduction, and we're working on seeing if we can build a stronger bridge with OCOM as well. And so it's changing, I think. We're unique in Portland, Oregon, in that we have these rich resources that all of you are a part of. And I'm not sure you could say the same thing necessarily for like Elko, Nevada, but I don't want to trash Elko, Nevada because they don't really know what their resources are.
Well, let's take Miami. The consortium is had a conference in May of 2012 here in Portland, and they had 200 local attendees from the integrative medicine community. In 2014, they had a conference in Miami, and everybody knows Miami is much, much bigger than Portland, Oregon. They had 4 people from Miami come.
Okay.
So that'll just tell you the interest is here in a way that it's often not in other parts of the country. I mean, we have UWS, we have Pacific, we have OCOM, we have NCNM, we have an osteopathic school down in Lebanon. It's a rich environment.
It is rich.
I think in the settings that I've worked with, the emphasis has really been on more of a bio-psychosocial spiritual model, and that tends to be the orientation for palliative and end-of-life care anywhere that it's being done. So really looking at the family as the unit of care and really emphasizing all parts of well-being, not just the physical parts, but all the other dimensions that make someone human. That's one really unique thing about palliative and end-of-life care that really drew me to this area was the fact that it is so interdisciplinary and more holistic than maybe other areas of medicine might be.
Questions?
I don't actually know too much about this, but I was wondering if you could speak about, or I know Oregon is one of the only states that allows for assisted death. So speaking about that in terms of end-of-life care and just what you've seen with that regulation.
You're most current.
Because I'm writing a talk on that today. This afternoon, writing the latest. So we were the first state to approve by a voter ballot initiative what was called Oregon's Death with Dignity law. California had attempted to pass that legislation, as did Washington. Washington was actually the first state to propose it, but we were the first to actually approve it in 1994. And it was immediately stopped in the courts, and then it was taken back to the Oregon voters in 1997 and was approved by an even bigger margin at that time. And here's just a little bit of trivia for you. The only time that Oregon voters have voted on the same issue twice was death with dignity, and then back in the 30s, and the question was, should Oregon voters pay for the legislators to take the train to Salem? Just a little trivia. So a number of us were involved with it was called the Oregon State Task Force for Terminally Ill Oregonians, while the whole thing was held up in the courts, because we weren't sure what was going to happen. We didn't really know what to do. We didn't know what it really meant. And so we were tasked with both making sure that we really educated both the public and the healthcare community about end-of-life issues, end-of-life care, hospice care, pain management, all those kinds of things. And then the other thing we were asked to do was write the guidelines for the law. There were many, many court challenges that existed for the subsequent years, and the law has remained intact for 16 years. I was just today reading that now there are 5 states where this is legal, and 2 more about to vote, Massachusetts and New Jersey, but 28 states have had the ballot initiative. And in the beginning, what the law requires is that you have to be 18 years of age or older, you have to be an Oregon resident, you have to have capacity, meaning decision-making ability, understand what one is choosing, and you have to have 2 physicians determine that you're within the last 6 months of life based on the diagnosis that you have. And you have to make 1 written and 2 oral requests 2 weeks apart from one another. And in the beginning, I think everyone was very, very frightened about what this meant, and was everybody going to move to Oregon to do this? I think providers were fearful that it was somehow a statement against our ability to care for people well at the end of life. And the data has remained really consistent over the 14 years that we've been able to gather it. And the top 3 reasons that people make the choice to pursue what's now being termed physician aid in dying one is the desire to control the timing and manner of death, the desire to maintain dignity, and the desire to leave life while they still have some quality that they associate with it. There's not been evidence that pain, depression, or financial burden are the primary concerns. Oregon's unique. We're still a primarily white state. We're the least church state in the nation, and the average has remained pretty consistent, that it's primarily white individuals. The average age is 72 years of age. Primary disease is cancer, followed by ALS, and that the data has just remained consistent, that it's like 1 in 10,000 annual deaths is as a result of Oregon's Death with Dignity legislation. Many more people talk about it, slightly less will actually follow through and get a prescription, and even less actually take the prescription.
How many people have a living will? You must know this statistic too.
I don't, but I should. Do you know your
I don't know.
I was just talking to a lawyer who's on the board of a school board, and we were just talking about estate planning and things like that, and she said that she's really always surprised about how few people actually have a living will. So it made me think about it, because I don't have one, and that's the next thing I'm going to talk with her about. It. I think everybody should have a living will. Like, what do you want to have done? And it's so easy to not think, oh, I'll do it next year, you know. We don't know how that goes.
So, I was involved with the Oregon Nurses Association when the Oregon Death with Dignity law was passed, and so we were charged, the Ethics and Judicial Committee, to come up with guidelines for the nurses and how would they or practice be affected by this. And we called the national office and they said it's unethical and they hung up. And I was like, well, that doesn't really help because we have nurses here who, need to figure out how to work with this. And this was like 20 years ago. And so, we came up with the guidelines that supported nurses who wanted to be involved and didn't want to be involved. And I think that's really important, is that it really is a conscious decision and no one is forced to be involved or not to be involved. And what I teach the nurses when I'm answering this question at the School of Nursing is, when somebody asks about death with dignity, there's two responses I absolutely do not want to see or hear about. And one is, wow, man, I've been waiting for you to ask that. Because you then set up in motion expectations, and it's the beginning of a dance. It's the beginning of an exploration. It's the beginning of exploring with that patient what it's like to live with a life-threatening illness, what it is like to be facing their death. And the other thing that I don't want nurses to do is cross their arms and say, I can't talk to you about that. It's against my moral code. Because there's nothing against our moral core, our practice and our morals to have a discussion about what patients are experiencing. And having a discussion doesn't lead to you supporting or not supporting a patient in that decision. And so keeping the dialogue open, I think, is the most important thing.
There's some interesting data that suggests that because we can talk about it openly in Oregon because it's legal, that it actually decreases the risk. Now, I don't know that that's actually true or not, but it does give us, as Mary Denise suggested, a real opportunity to dive more deeply into that person's experience and their view of what's happening, their view of suffering. There are certainly some things that we can do to help support them, and especially if their suffering is related to something we may be able to ameliorate, then that's an opportunity we have to. I think it's 20% of this academic.
Really?
I've been thinking that.
I was thinking 25%, so. Yeah.
Well, it's interesting, just from having lived in Santa Fe and been involved with Upaya and up there and just kind of being interested in Buddhism, there's a whole thread in Buddhism about, while you're alive, focus on your death. Focus on the fact that you're going to be dying, and it's not out of a morbid fascination that's going to be depressing. It actually frees you up to live more fully. And so it's an interesting little way to look at things.
Let me ask, how many of you have an advance directive? An advance directive, where you outlined your wishes about your death and who should speak for you.
I just haven't legalized it yet. It's all written out, though.
Oh, so an advance directive, it's a way that you can have your values and your wishes honored when you lose the ability to speak for yourself. And so it has two parts. One part is that you get to name who's going to speak for you if you can't speak for yourself. And that's a very powerful ability to have. And when I did mine a number of years ago, and I put down my sister, and then I filled out the rest, and you talk about if I'm close to death, if I'm permanently unconscious, if I have a progressive illness and I've lost the ability to speak and communicate and eat or drink, or if I'm having extraordinary suffering, would I want life support or not, is basically it. And then you can write other things. So I filled mine out, and I went and I talked to my sister, and I said, okay, I've named you as my surrogate, and this is what I want. And she goes, I can't do that. I said, phew, thank heaven we had this talk. Give it back to me.
Yeah.
Give it back to me. And so my surrogate is friends of mine who live in Virginia. And people go, well, they live in Virginia. And there's telephones, there's Skyping. They can be involved in the decision. So I think thinking through who can best represent you is very important. It doesn't have to be notarized. You have to have two people witness it. And then we encourage you to distribute it widely so that when and if you need it, you have that available. And what our research tells us when we've interviewed family members following the death of a patient is that if they had an advance directive to look at, that their bereavement is much less complex and that they move faster through their bereavement process. Even if they were 100% certain that they knew what you wanted, being able to look at your handwriting and being able to reflect on the discussions that you've had really helped them. And this is the first generation of family members that I think that are consistently being asked to make these end-of-life decisions, because as David said, we didn't have this technology 40 years ago. My mother never had to make that decision about her mother. And what we're learning is that it is a huge burden on families to have this responsibility. Families that have this responsibility in our ICUs, many of them suffer PTSD and stress-related illnesses. And so what we're now trying to figure out is how can we make the hospital environment more supportive of family members who are in this position.
One of our colleagues, Eric Frome, who is a palliative care doctor at OHSU, often talks about how we mix up advanced care planning with end of life. And if any of you remember Terry Ann Shivo's story, the issue at hand was that her wishes were not written down. She was no longer able to speak for herself, and her husband had one belief system about what she would have wanted, and her parents had a different belief system. So we really encourage anybody age 18 or over to have them, because life is risky. We drive cars, we cross the streets, we have children, we have a lot of reasons. We go kayaking, we have a lot of reasons that it would be a good idea to write this down, but it's a hard topic to approach, which is, I think, the reason why many of us have not done that. But choose your surrogate carefully, as Mary Denise suggested.
Questions? No? Okay. So for the next question, how is the loss of a child and the loss of an adult companion different when you guys are trying to help people cope through this? Not only the person that is passing away, but also the people around them.
Can you repeat that?
Oh, yeah. How is the loss of a child different from a loss of an adult companion for both the person that's passing away and their loved ones around them?
Yeah, I think the biggest difference is that the loss of a child is it's an off-time event. So it's not expected that a parent would outlive a child, that it's not something that we have children and expect that we're going to outlive them. So, I think that can make the experience much, much harder to live through, right? Most of us expect that we will outlive our parents. That's a sort of a normal developmental progression. But when it's the loss of a child, especially a young child, that can be really, really hard for the child's siblings, if they do have siblings, but for the parents as well as the grandparents, if they're still alive, that that sense of this isn't supposed to happen this way can make it a lot harder to adjust to and to cope with. Not to say that losing an adult family member is easy either, but in a way it can be a little bit more expected. That can make it seem a little bit more like this is a natural part of life.
It also it makes a difference in the suddenness of the departure. I know that when I was working as a kidney transplant coordinator, it was always an accident. It was always sudden. And if there was organ donation, they were usually younger and healthier, usually around a car accident, frankly. And but that was always much more traumatic. And actually, when I went to medical school, I actually changed the way I viewed cancer. Partly as a result of my father-in-law passing away from cancer, and that he had about a 2-year period of time during which he was able to dialogue with his family about what was happening, what was going to go on, what he wanted. And he was one of these meticulous planners, so everything was totally planned out around his death. And I began realizing that actually cancer is a way to bring your mortality into focus. And it can be taken advantage of, too.
It's painful. I was part of a study recently where we looked at the treatment practices of oncologists if their patient was a young parent. And what we looked at was the desire to continue to treat and treat and treat, both on the part of the young parent and also on the part of the provider. And often the providers were the same age as the young patients and had their own young children. And it was really an interesting and painful study because, as I remembered clinically, the young parents that I worked with often just did a lot of bargaining around, I'll do anything to stay alive long enough to see my child graduate from high school or whatever year it might be. And when that wasn't possible, it was incredibly painful.
With regard to mental health treatment, are there any specific treatment modalities or goals that are more common or most effective?
Yeah, I mean, so
She's great at it.
As a psychologist, now I work in an outpatient mental health clinic, but when I was finishing up my graduate training, I worked at a VA hospital and worked on an inpatient hospice unit, as well as a couple other areas where there were palliative and end-of-life concerns. So a lot of what I would do in those settings would be